I'll let you know when to advance the slides because I do the first few. Is that okay?
Oh, you're doing the first few?
Yeah, I do 1, 2, and 3, and then turn it over to you.
Okay, great. So I'll go ahead and set it up.
Yeah, so just go ahead and share like you were.
Okay.
Welcome, everybody. Thank you for joining us and welcome to the first session of the 3D Echo Child Psychiatry Clinic. My name is Sharon Phelps. I am with Mountain Pacific Quality Health, and I want to thank you for spending a few minutes with us today. The Echo model is the extension of community healthcare outcomes, and 3D Echo reflects our commitment to support the full range of biological, psychological, and social dimensions of healthcare in our communities. The Echo model engages participants by providing short, targeted, evidence-based content followed by real-life case studies in which all participants learn and contribute. Next slide, please. First, a few general items. Here is the disclosure statement for your information. These slides will be sent to you in a few days, and this information will be included. After this session is completed, a survey will automatically pop up so you can give us feedback on how to make these sessions better. Lastly, an Echo session is meant to be a less formal presentation with participation from the attendees. We encourage you to turn on your cameras so we can see you and engage with you during this session. And please feel free to put your questions or comments in the chat box at any time during the session. Next slide, please. The Echo series on child psychiatry is open to pediatrics, primary care clinicians, case managers, and nursing homes, case managers and care coordinators. This 10-part learning collaborative offers you the opportunity to get expert consultation and input from your peers on your most difficult patient scenarios. Everyone benefits from discussion on these cases, and we are actively seeking cases to review. Our host for this series is Dr. Eric Arzubi. Dr. Arzubi co-founded Frontier Psychiatry in 2019 to introduce an accelerated, more aggressive response to Montana's growing mental health crisis. He served as chair of psychiatry at Billings Clinic from 2014 to 2019, during which time he led the creation of Montana's first psychiatric residency training program and the launch of Montana's first empath unit, a service dedicated to providing timely care to individuals in crisis. In 2020, the Montana Medical Association presented Dr. Arzubi with one of its top physician awards, the Dr. Jack McMahon Service to Montana Physicians Award, for his contributions. Dr. Arzubi is assistant clinical professor at the Yale Child Study Center, where he supervises child psychiatrists in training. Thank you for hosting this series for us, Dr. Arzubi, and I'm now turning it over to you.
Thank you very much, and thank you everyone for joining. Today we'll be talking about anxiety disorders, and actually what I'll do is I'm just going to unshare for quick and a second and just kind of chat with you all. So we'll be going through a series of disorders related to childhood mental health, and we'll be starting off with anxiety disorders. And one of the reasons you'll see that we're starting off with anxiety disorders is actually they are the most common disorder among children. They're the first of the several disorders that are out there. This is the first one to show up in children, and like I said, it's the one that's the most prevalent and is most common. So one of the things I'm hoping that you all will get from not only this presentation but the series itself is information about each one of these disorders, how to identify them, how to treat them, but then also get a broader context of where they fit into sort of childhood development and child mental health presentations in general. So again, I'll go ahead and share my screen and we'll continue. And then the other thing that I would invite people to do is reach out feel free to interrupt me with questions, throw questions into the chat, and happy to do that. So let me go ahead and do that. Okay. So again, a few things about anxiety. There's a bias among patients and providers that it's actually less serious or less debilitating than depression. Saying, gosh, it's just a normal part of life, and that's obviously not the case. Anxiety disorders are, especially for those who struggle with anxiety disorders, it's very much a potentially debilitating problem and symptom. And in fact, there's some research to show that, while when we think about kind of suicide risk, it turns out that anxiety is also a risk factor for suicide. In fact, there's a paper back in the 90s that reports anxiety being a particularly important risk factor, as well as sleeplessness, as you can imagine. So that's an important thing to keep in mind. Interesting also is that youth with anxiety disorders were the least likely to receive treatment in a 12-month period among a sample of youth with psychiatric disorders in general. And so that's important too, because anxiety tends to be sort of an internalizing disorder, right? So it's not like ADHD or some sort of severe behavioral problems that are kind of expressed physically or in other ways, so are these externalizing disorders. But when it's sort of internal, then harder to see, and then obviously the harder it is to see, the less likely you are to kind of treat it.
Dr. Arzubi?
Yes.
We are not seeing your screen, and I think you were intending to be sharing at this point.
Oh.
Thank you.
Okay, sorry, how's that?
That is good, thank you.
Good, sure, sorry. So again, just briefly, the bias. So again, the bias that among patients and providers, that it's less serious than depression. Youth with anxiety disorders, again, less likely to receive treatment than many others. In childhood, male and female rates are actually similar in terms of anxiety disorders. And in adolescence, it starts flipping more towards females having more higher likelihood of having an anxiety disorder than males. And then signs and symptoms that can be associated, right? Obviously anxiety is, kind of in the simplest terms, is excessive worry, right? It's excessive worry, or worry in out of proportion to the thing about which one is worried, and that causes, and again, like every psychiatric disorder, one of the important definitions is that it causes impairment in functioning. So that's critical as well. So in terms of signs and symptoms, beyond anxiety, it can lead to low self-esteem, social isolation, which then can contribute to having poor social skills, higher rates of somatic symptoms, meaning you could have headaches, stomach aches, irritable bowel syndrome, among others. So again, I think for those of us who treat children, and for those who present with anxiety, some of these physical symptoms are certainly things that we see. A little bit more about anxiety. Turns out 30% of youth with anxiety disorders also have comorbid depression. So like many psychiatric problems, they travel together. And up to 41% of adolescents with major depressive disorder had or have anxiety that preceded the depression symptoms. So that's an important. So again, just understanding that anxiety, like many disorders, kind of travel together with other disorders. So I want to just show off a few different presentations of anxiety. This comes from this paper called it's a practitioner review, and again, you'll have access to the slides, so you can go to some of the research that I might be citing here. But you'll see, and again, I apologize for the small print, but essentially, I'll go through some of the different anxiety disorders, right? So there's separation anxiety disorder, which is excessive fear of separation from primary caregivers. There's specific phobia, which is fear or anxiety about a specific object or situation. Social anxiety disorder, right? So that's fear, anxiety about social situations in which the young person is exposed to possible scrutiny by others, So really, that attention that they'll be getting from others. Generalized anxiety disorder is excessive and uncontrollable worry about a number of events or activities, and has 3 symptoms associated with that include muscle tension, difficulty concentrating, and sleep disturbance. Panic disorder, recurrent unexpected panic attacks that aren't restricted to particular situations, so they can kind of happen in any context. Agoraphobia, so marked fear or anxiety about 2 or more of the following. So using public transportation, or being in open spaces, or even being in closed spaces, or being in a crowd, or standing in line. And then selective mutism, a consistent failure to speak in specific social situations like school or others where there's an expectation to speak. So again, lots of different sort of flavors, if you will, of anxiety disorders. Again, separation anxiety disorder, specific phobia, social anxiety disorder, generalized anxiety disorder, panic disorder, agoraphobia, selective mutism. So this is an important paper that I'll be referring to periodically throughout the series. It's important when treating children with mental health problems to really understand what's the epidemiology. What are you most likely to see? What are you most likely to see? And so that's why this is important. So this, again, sorry about all the numbers, but what I'm doing here, can you all see the cursor?
Yes, we can see it moving.
Great. Okay. So here we have mood disorders and anxiety disorders, and this table goes on, but I just kind of pulled out the mood disorders and anxiety disorders. You'll see at the top here it says, female versus male, age, right? 13 to 14-year-old, 15 to 16-year-old, and 17 to 18-year-olds, and then total. And then this is kind of with severe impairment. But I want to draw your attention to this number down here, 31.9%. This indicates that 31.9% of all individuals before the age of 18 will have met criteria for an anxiety disorder. So again, 31.9% of all individuals up to the age of 18 will have met criteria for an anxiety disorder. So that's pretty significant. A third of the population will have had anxiety before turning 18. And again, we'll go over this down the road, but you'll see here that the number for depression or any mood disorder is 14.3%. 14.3%. This is a graph that shows the relative prevalence of the different disorders. So you see the orange here, anxiety disorders, and you'll see this is cumulative percent. That means as people get older, what percentage of people by the age, for example, if we pick this one, age 7, by age 7, it looks like around 16% of the population will have experienced an anxiety disorder, right? And so this is where you eventually get to the 31% we saw before. So again, the orange here is anxiety disorders. The blue are are behavioral disorders. Like ADHD, conduct disorder, DMDD, that sort of thing. The green are mood disorders, and then purple here at the very end are substance use disorders. So this is and it makes sense, right? Substance use disorders kind of trail off at the end. So next, I'm going to show you kind of a little bit of an algorithm, and I'm showing. This is sort of from a website, the Seattle Children's, it's called PALS for Kids, so Partnership Access Line for Kids. That is a great resource that I encourage all of you to kind of take a look at. It has these care guides that provide some wonderful information, and especially for, if you're treating kids and need ready access to information, this is a way to kind of tap into a really good resource. But here's the sort of the basic algorithm. So starting at the top, if you're considering an anxiety problem, are there unexplained somatic complaints? Then you do a safety check. Is there neglect or abuse? Is there drug abuse? Is there a medical cause? What if so? Are they medication effects or asthma? And then if once you've ruled out sort of these different things like neglect and abuse, like active neglect and abuse, drug abuse, and medical cause, then you think what else could be showing up with these anxiety symptoms? And so, as you can imagine, that we've indicated before, depression is common, and ADHD is also common as a comorbidity. Around 50% of children with anxiety have two or more anxiety diagnoses. So again, even anxiety disorders themselves kind of travel in clusters. So somebody with separation anxiety is more likely to have another anxiety disorder as well. In terms of diagnosing, you have the DSM-5 criteria, which again you can certainly look up. A really nice screening tool for anxiety is the Scared Anxiety Scale. And again, it used to be in the DSM-4 that OCD and PTSD were under anxiety disorders, and that's sort of been separated, but you still want to kind of make sure you're paying attention to that. So if there are significant obsessions or compulsions, you may want to consider an OCD diagnosis. If there are nightmares or flashbacks or trauma, you want to make sure you're considering a PTSD diagnosis. And then, if there's anxiety and excessive worry, but you're not sure, obviously you can start off by saying, okay, this is unspecified anxiety disorder, and go from there. And so the question is, here in the algorithm, can it be managed by primary care? If yes, consider if it's a mild problem or moderate severe problem. If no, then you can make the referral. But let's kind of keep going in the algorithm. If it's a mild problem, generally the functioning is not severely impaired. It's noticeable, and a lot of reassurance can be helpful. So, for example, saying a lot of kids can feel this way. Talk about the distorted thoughts. Reduce some of the stressors that are maybe leading to this point. It can offer a tip sheet, which actually is available on the website about relaxation techniques. Also, paying attention to how's the parent responding, right? If the parent is highly anxious, then you can encourage them to get help as well. Can offer obviously some other resources and talk about how somatic symptoms can be sort of stress pains or something similar, and just discuss the link between kind of the body and the mind. In terms of a moderate to severe problem, first line, individual psychotherapy, but really if we can get away with, if we can do it, is really CBT. Cognitive behavioral therapy is critical and preferred. The key element there is a gradual exposure to fears, and also really emphasizing the link between thoughts, feelings, and actions. And then if therapy alone is not helping, or if you're already identified that the anxiety that's being treated is severe, then low dose fluoxetine or Prozac, or sertraline, which is Zoloft, are the first line choices. Using therapy alone before medications, unless it's, again, the guidance here is you try to use therapy alone before meds unless it's really impairing. And then wait 4 weeks between increasing SSRI doses. And then if there are no side effects, really try to be assertive with the dosing of the SSRI. Want to make sure and check in for agitation or suicidal thinking by phone or in person in 1 or 2 weeks, and stop medicine stop the medication if there's agitation or increased anxiety. And again, can try a second SSRI if the first isn't helpful. In terms of the anxiety screening tool I mentioned before, this is the Scared Scale. And the reason I'm going to show you, again, sorry, it's a little bit of a list, but it's a really nice, it gives you a really nice outline of all the different anxiety symptoms that can be presented. So again, the directions here at the top, you see the directions. Okay, here's a list of sentences that describe how people feel. Read each phrase and decide if it's not true or hardly ever true, or somewhat true or sometimes true, or even very true or often true. Then for each sentence, fill in one circle that corresponds to the response that seems to describe you for the last 3 months. So again, long list, and you look up the Scared Scale and you can take a look at this, but I'll just read kind of just a couple different examples. Like one at the top, it says, When I feel frightened, it's hard for me to breathe. I get headaches when I'm in school. I don't like to be with people I don't know well, and so on. And the way to score this is actually really nice in that it'll give you two results. Number one, it'll say, hey, is this person likely to have an anxiety disorder? Yes or no? And then it'll also give you kind of more specifics on what type of anxiety disorder is most likely. But again, what I like about this screening tool is that it gives you a nice long list of many different ways that anxiety can present. So it's a good reminder and a good tool. So again, real brief here. The mild to moderate treatment. Treatment for mild to moderate anxiety is CBT, or cognitive behavioral therapy, and moderate to severe anxiety is cognitive behavioral therapy plus medications. And then here at the top are the two medications that are you really, if you're somebody who prescribes or really need to understand the medications that are involved in the treatment of anxiety, really, really understanding that these two medications are critical. Fluoxetine or Prozac is a very well-known long-acting SSRI. And then you can see the different dosing forms that exist. Generally, for adolescents, you start at 5 to 10 milligrams and can go all the way up to 60 milligrams if needed for anxiety disorders. And then sertraline, you can see that the starting dose tends to be 25 milligrams, and you can go all the way up to 200 milligrams. But certainly these are the two most common, and getting at least a feeling for what doses look like is important. And these are a list of other medications that can be used to treat anxiety. Now, what's really interesting is the only FDA-approved medication for generalized anxiety disorder in children is actually the very bottom one, duloxetine. But it actually does not work as well as these two, fluoxetine and sertraline. And that's the presentation. Any questions or comments about the presentation, anxiety disorders?
Dr. Arzubi, did you have a case study for today, or would you want to open it up to our participants if anybody has a case study or questions on a particular case they would like to discuss?
So I think I'd like to open it up if possible to see if there are, I guess I'd like to get people's thoughts on, are there particular cases, are the cases that they have that they're dealing with right now with anxiety, or questions related to the presentation.
You had mentioned a tip sheet, and you said it was on the website. Can you share that link?
Sure, happy to do that. I'll do that right away.
In your own practice, Dr. Arzubi, have you seen a change in childhood anxiety disorders with COVID and all the changes that happened with school?
Certainly, the anxiety disorders, yes. I mean, certainly I would tell you that there's a higher, you're seeing anxiety disorders, I think, show up more often. And I'm just sending you here the link. Let me just send it out to everyone. Okay. So certainly, I think that it's probably true also for adults. Certainly the prevalence of anxiety disorders has gone up as kind of the tension, I think, around sort of in the community and certainly around COVID has risen as well. So I would tell you that, yeah, you're probably seeing more. And again, it's, a lot of stuff is kind of comorbid that comes with both the anxiety, but also some of the other disorders. Looks like question, is there a medication that tends to help reduce skin excoriation? So skin excoriation, so that's kind of skin picking disorder. There's no one great medication for that. Certainly the treatment I would start off with is is like sertraline or fluoxetine for anxiety if it's likely comorbid. So you want to treat the underlying anxiety disorder as well. And for skin excoriation itself, it's almost doing. There's something called habit reversal therapy where you help the person who has this disorder. You replace what they're kind of doing with their hands with something else, and that's called habit replacement therapy. That tends to be useful and helpful as well. But there's not a great medication that kind of targets a skin excoriation, and sometimes people will take fluoxetine or sertraline and add to that another medication like Seroquel to kind of help augment the treatment for those symptoms.
Another question we had, Dr. Arzubi, is on slide 17, under the editorial comments on those medications, there is the abbreviation of SE, and I think that means side effects. Is that correct?
Correct.
Okay, thank you.
Of course. And I guess I'm curious for the group, has the group seen sort of an uptick in kids presenting with anxiety disorders, and what are you seeing now compared to, let's say, before COVID?
So I'll go ahead and answer. I'm in Libby at Northwest Community Health Center. With the kids that we're working with, I think there's still a lot of school-related stressors because of a lot of kids fell behind when they were doing kind of online schooling. And so that seems to have carried over into this new school year, even though they've been in person. So it just seems like, again, trying to adjust to being back in school with a consistent schedule. And I think the school systems in Libby have a Schedule A and a Schedule B. So they've still kind of changed things or kept things changed. And the kids that we're working with are having a really difficult time. And we're seeing a lot of new students come in for services. And most of it is kind of school-related stressors, something within the environment. And I think that's probably a carryover with just a lot of the kind of the general stress that their parents are feeling, and not being able to get the support at home that they're typically used to because their parents are still trying to get back to some sense of normalcy, whether they've lost jobs or the housing has been a big issue here, where a lot of people have been displaced because rent has gone up and or their homes that they were renting have been sold out from under them. So there's just been a lot of transition, families moving in with grandparents, that sort of thing.
Thank you. Yeah, no, certainly it's caused sort of an upheaval in a lot of the family structure for sure. So that just kind of compounds things. There's also a comment there, a lot of adjustment issues for the kids who missed 2 years of in-person school. Also with college kids whose last 2 years of high school were online. Yeah. It just threw off a sense of normalcy and threw off also routine, right? Routine and that structure is critical. So that's certainly a predictor of future feelings of anxiety. And then from Kate G here, some of the extra stresses we have heard about are struggling with changes within their own environments. Yep. Or relate to adults being more stressed around them, for sure. And in fact, early on in the pandemic, one of the big concerns was, is with parents being more stressed and perhaps resorting to, let's say, drinking alcohol or other kind of coping skills, or not really coping skill, but coping approaches, is that, and for kids especially who are already vulnerable or at risk of being abused, is that we saw more likelihood of kids being abused because everybody's kind of stuck at home. Stress is going up, financial stress for the parents, other stress for the family, and certainly that had an impact. The other kind of thing I wanted to bring up too is that sometimes this could be a typical case would be where a young child. So first of all, kind of reminding folks about the epidemiology of all the different mental health sort of disorder, the mental disorders that show up in children. I think it's important. I think it's important that we keep in mind, right, with all the children that come in, that we understand what's the most likely thing they're going to see. The most likely thing what we're going to see is anxiety disorders, right? Because that's the most prevalent. So kind of keeping in mind as we go from most likely to least likely, just making sure when somebody shows up, is it an anxiety disorder? Making sure, is it a behavioral disorder? And kind of keeping in mind what are the most likely things to happen first, or what are the most likely things that are going on, anxiety disorder being one of them, and then going down the list. The other thing is if there's kind of both anxiety disorders and ADHD, for example, sometimes the question is, well, what do you treat first? Well, my approach tends to be, ADHD when, if it's truly ADHD, taking an approach where you treat what's treating ADHD with a stimulant is more likely to get you a pretty quick benefit versus starting an SSRI for anxiety disorder. So you want to start with the stimulant because that's most likely to get you benefit, and then you see kind of what's left. But that's in a situation where you have both. I'll go for the one that will get me the best or the quickest result if I know that both are present. Other questions around anxiety disorders or related? And are there any cases in particular that folks are thinking about? One of the things, just a comment, is, as many of us know, that the presence of sort of adverse childhood experiences, stress, trauma at home is very common, right? It happens in two-thirds of adults have one ACE or more. So just keeping in mind that as a potential kind of cause of what's going on. So making sure you're screening for any trauma in the assessment process. The other thing is in children with severe anxiety and PTSD, there are sometimes we think about or we hear about kids having hallucinations. It turns out that actually anxiety disorders are more likely to cause sort of a sense of that there might be hallucination than anything else in children. Because true hallucinations, because of either bipolar disorder or because of schizophrenia, that really doesn't show up till late teens, early adulthood. So if a child is talking about what might sound like hallucinations, the most likely cause is severe anxiety. And I invite you to think about, imagine you go see the scariest movie you've ever seen, and then you go back into a dark parking lot and you're by yourself, you're going to start seeing things and hearing things, so that's it's just an important point to make, that the most common cause for things that might sound like hallucinations are anxiety disorders. Here's another comment. We've also noticed and heard of kids struggling with so many unknown fears that popped up because of COVID, disease or secondary effects from the pandemic, and how to process them. What are some good ways to go about helping them understand what their fears are and then being able to move forward from that point and dealing with them? So the great question. Generally my most the most important piece of I guess advice I'd have for folks talking to parents and parents talking to children is, understand understand what, first of all, validating the feelings, right? Validating feelings by the child, and listening, right? Because one of the things we try to do is to try to kind of squash anxiety. Because if a child comes and says, "Oh, I'm anxious, I'm terrified of this," we try to say, "No, it's gonna be fine. It's gonna be fine. It's gonna be fine." So what I would do is make sure, kind of keep the door open for conversation about, when they're feeling something, let them come forward and talk about it. And so I think, so number one is certainly validating. And number two is really, ultimately what child therapy does is it gives children the language, to talk about what they're experiencing. So part of it is it's almost like you're tutoring them on how to express themselves about different things they're experiencing. Other questions or comments? Okay.
If you would like to share your slide deck again, Dr. Arzubi, on the second to the last slide, we do have a list of the topics that are upcoming in future sessions, as well as the dates for those.
Of course.
Thank you.
Me. There we go.
There.
Wonderful. Oh, there are no more questions. I thank you so much for everyone for attending. Again, encourage folks to bring real cases to these conversations, because as you can imagine, they bring they bring up issues that I think many of us are facing. And yeah, and feel free. Like I said, I'm trying to make this as interactive as possible. So I look forward to future presentations and discussions. Okay. Oh, got it. So yeah, a family, multiple children, and one who's been diagnosed with cancer, separation issues, because of travel for treatment, et cetera. Will be a good way to deal with it. Yeah, so I would suggest a lot of education about kind of what's happening, because I think one of the things that might happen in these situations where people try not to reveal too much, and when people are trying to avoid revealing too much, it becomes a problem, because then kids are smart and they start making other assumptions about kind of what's going on. So I think being as transparent as possible, doing as little hiding as possible, and the more educating you can do, the better. Again, therapy could be helpful, but I think kind of the family as a group kind of coming together, I think makes the most sense. And that way they can learn from each other and promote each other as supports. And then childhood abandonment issues. What's the question there about childhood abandonment issues? Oh. Got it. Yeah, that's hard. Because it's hard to, right? Because then there's this kind of anxiety on the part of the father, part of the child, of how's dad? Is dad safe? That's a tough one, because what's happening there is the actual cause of the anxiety is continuing, right? So it's kind of being perpetuated in a way that's not being stopped. Oh, and doesn't call for months. Yeah, that's hard. And actually, goes back to the structure of, the family. I mean, well, yeah, that's a whole, yeah, exactly. And that, the child is 4 but smart, and she's already saying things like, "Why doesn't my dad love me?" It's that the only good solution there is really that's in dad's court. in terms of the efforts, making the efforts to kind of stay connected. I mean, there's no, like in my mind, that's not sort of a disorder. That's not a childhood disorder. That's kind of a parenting and attachment problem that the father, if he's able, I'm just thinking, if he's able to call during Thanksgiving, Christmas, and then January birthday, I got to believe there are other times they could be calling too. That seems 9 or 10 months without calling seems like a pretty big stretch. Kids with social anxiety and isolation during pandemic was hard. Yes. How to help them gain confidence and re-engage. That's gradual reintroduction into what were more common situations before. So it's almost like exposure therapy, right? So if being around other kids in school and so forth is anxiety provoking, it's almost like getting into cold water. You have to do kind of gradually. And so that's kind of slow reintroduction before. So it's kind of like exposure therapy. So that would be probably the best approach for this sort of patient.
Zubi, I have a question about a case. I did an assessment last week on a kid. He's a second grader. He's 8. I'm thinking a separation anxiety disorder. He has some pretty extreme behaviors, basically when he's going to school every morning and separating from mom, getting pretty physical, and does not want to separate from mom at all, but also has some other anxieties. It's so hard sometimes because there's so many things contributing. I wonder about some trauma. He was removed at one point as a child, and then there's kind of some of those extreme oppositional behaviors. So kind of where to go with that, but also wondering if you have any suggestions for any trauma screens. I'm always kind of trying to find something that's helpful to kind of possibly rule that out.
And how old is the child?
He is 8.
Got it. 8 years old. And who lives at home?
Mom and fiance, but he is gone pretty often because he works for the railroad. So.
Got it.
And mom has 2 other kids at home besides him.
And is there trauma for sure?
The only trauma I know of is just the separation, being removed from CPS. That's the only other trauma.
And the child was separated. Sorry, the child was separated from this particular mom before?
Mm-hmm.
Got it. Yeah, and I guess I'd be wondering about a couple different things. Is number one, what was the reason for the separation? And so so probably there was a reason for the separation that may have caused a lot of problems, and certainly set this child up to struggle. And then the separation itself, and then now kind of the memory of that, both what was happening before and the separation itself, as cause for ongoing anxiety. So that makes some sense. I guess the other thing I kind of wonder about is the fiance. How long has the fiance been in the home and in the person's life? That consistency is an issue. And I guess the other piece I wonder about is the bio dad, because sometimes I've also kind of run across this where, the biological father kind of floats in and out of the family, and every time they float in, it kind of causes chaos, and floats back in. And so, so there are a lot of kind of different moving parts to this. Is any of that happening?
Yeah, he doesn't see dad very regularly. He'll sometimes take him on the weekends, but mom said it kind of depends on dad's mood and kind of where he's at.
Mm-hmm.
And he's struggled with sobriety. And the other interesting thing that the school noted was that mom was gone for work for a few days, and they had absolutely no issues with him coming to school in the morning. He came in just great. But every morning that she brings him to school, it's a fight to get him in the door. And he's like biting her and hitting her, but then also like it felt, I was able to witness it when I was there, because when she left, he started kind of escalating and just like pulling at her, and it just felt very like feral, kind of that fight or flight just response when mom was trying to leave.
Does how long was the child removed for?
For a month.
And how long ago?
It was a few years ago.
Okay. And is the child taking any medication? And I guess the other thing I wonder about is also the relationship between mom and the child, and how.
Yeah,
Again,
I think that's definitely part of it. Mom says she's not very great at following through and will sometimes give in to him. And I think she shuts down when he starts saying mean things to her, like, you're a great mom, or you're gonna, So then I think she just doesn't know how to respond to him. So.
Got it. Yeah, I think, the piece is helping mom with some more tools, I think is gonna be critical here as well.
Yeah.
Right, because the child's already traumatized, and so the best, in my mind, moms and parents at home are always the best interventions, right? And so if we can help, right, because the child is dysregulated, and what the child needs is a mom who is regulated, right? So if both are kind of dysregulated, then that becomes a problem. So right, the also will be interesting to see is, how's mom responding during those drop-offs? Like, how is she escalating? Is she keeping things calm? So there are lots of kind of layers. And then also, given the severity of this, kind of the biting, kicking, I think it'll be important to consider medication for a child like this. And maybe my first thought is something like, again, I don't mean to kind of prescribe here through ECHO, but one of the things to consider is we're saying clonidine, for example, clonidine. So that could be something that kind of reduces the fight or flight and the anxiety.
Yeah. Any suggestions though about what the school should do, or how they can support that transition from? Because she said he pretty much, as soon as they get to the school, he is just starting with, like she said, the whole car ride, he's fine. And then as soon as they get to school, it's like. Is
there somebody at the school that he trusts or likes?
I don't know. I think usually the principal is handling it, but he was saying some pretty negative things about her when I was there. So I'm guessing that relationship is probably pretty, but I'm guessing her interactions with him probably are also when he is escalated and when he's having a hard time. So that's probably, and I guess maybe I should talk to her about that if she's having any sort of positive interactions with him, so that's kind of.
Exactly. Well, that's a great point, right? Because a lot of times it gets to the point where mom and the child rarely have some positive time together. And so how are they doing that? Are they having positive time together? And the other thing is, sometimes what happens, I think that happens to all of us parents, is we're really good at picking out what child's doing wrong, but are we doing a good job picking out what the child's doing right? And really encouraging mom to identify those and really reinforce those. And here's a suggestion: maybe the drop off from the car resembles him being taken away from mom. Great point. Could it be a trigger response? Yeah, trying a different drop off routine. Great point. Mixing it up. Yeah. Let's see. How do we help patients that are presenting with possible flags for anxiety, depression diagnosis? We identify unsafe home environment, poor compliance, follow up, possible abuse factors, but reporting concern. Oh boy. That's a tough one. That's right, because you're hoping that right. So the question is, how do we help patients that are presenting with possible flags for anxiety, depression diagnosis? We identify unsafe home environment, poor compliance with follow-up, possible abuse factors, but after reporting concerns to the human trafficking hotline and social services and the FBI, the patient remains in this home environment. I'm at a loss with how to help my patient. I wish I knew. I'm sorry. That's That stinks. That's kind of a system. That's a system problem. That's more of a system problem rather than a, yeah, that's an unfortunate system problem we have. I wish I had a good answer for you. I'm sorry. All right. Thank you everyone so much for hanging here till 2 o'clock, and appreciate the questions. Thank you very much. Take care.